Hello, everybody. I'm Dr. Benjamin Cooley. I am a C-L psychiatrist in Indianapolis, Indiana. And today we are presenting on the neuropsychiatric consequences of vitamin deficiencies. We feel that we've brought a very interesting presentation to the CLP conference. We hope that this is informative, that it's a good review, and that it is also thought-provoking in some ways. None of the presenters today have any disclosures. Starting with the learning objectives and outline, we are going to identify signs and symptoms of major vitamin deficiencies in their relationship to various neuropsychiatric presentations. We're going to point out gaps in the literature and in the guidelines for monitoring and treatment of these deficiencies. We're going to challenge traditional stereotypes about who develops these deficiencies and the frequency that we find these in the clinical setting. And lastly, and more broadly, we hope to empower all CL clinicians to feel knowledgeable about when to check for deficiencies and empirically supplement various vitamins for their psychiatric consult patient. Looking at an outline, I'm going to be starting with thiamine. Dr. Tanius is going to start with vitamin B12 after I complete thiamine presentation. Dr. Holmes will look at folate. Dr. Adams, vitamin D, and finally, Dr. Winiger will look at vitamin C. Starting with thiamine deficiency and its neuropsychiatric consequences, this is a deficiency that's easy to miss, it's easy to treat, and if you don't treat it early and effectively, the consequences are grave. Let's start with a case presentation. You have a 35-year-old 9-week pregnant woman who has no psychiatric or substance use history, who presents with nausea and vomiting and decreased PO intake for 2 weeks. Symptoms are persisting despite treatment symptomatically with antiemetics, fluid resuscitation. Several days into the hospitalization, she develops decreased motivation, apathy, and notably disorientation. Psychiatry is consulted and diagnoses apathy abulia syndrome, and she is started on an SSRI. Several days after initiation of the SSRI, the symptoms and the withdrawal worsen, and a repeat neurological exam shows that she has inconstant nystagmus. A brain MRI is urgently obtained and shows the following: abnormal periventricular signals in the bilateral thalami. She is immediately diagnosed with Wernicke's encephalopathy, and with hours is started on parenteral thiamine, and symptoms gradually improved and then finally resolve. 7 months after she gives birth, the imaging findings on a repeat brain MRI also resolve. I like this case because of a couple of reasons. Wernicke's encephalopathy is commonly diagnosed in patients with alcohol use disorder, but it's infrequently thought of in patients with other causes of nutritional deficiency. The other reason I like this presentation of this case is that psychiatry is involved early, and it is one of the first consulting services that comes on board and assists in treatment and management of this patient. A little bit of background on thiamine. Animals cannot synthesize thiamine. It must come from the diet, and it's naturally occurring in beef, nuts, oats, eggs, seeds, and legumes. And in the modern day, it is fortified in pastas, rice, cereal, and bread. The recommended daily intake is 1 to 2 milligrams. Total body stores are 30 to 50 milligrams only. It is hydrolyzed to free thiamine by phosphatases in the intestinal lumen, and free thiamine is absorbed by the small intestine. Once it's absorbed, it's active as thiamine pyrophosphate, and it's a cofactor in essential biochemical pathways, including the pentose phosphate pathway, the glycolysis pathway, and the TCA cycle. Without external thiamine, deficiency develops within 3 to 6 weeks. Just looking at the thiamine pathway through absorption and into its active form, it comes in the form of food. It's absorbed as free thiamine, converted to thiamine pyrophosphate, which is its bioactive form, transported by erythrocytes to the CSF, liver, and heart. And you can see here where thiamine pyrophosphate functions as a cofactor in various enzyme and biochemical processes. And just looking at those biochemical processes a little closer, we have the pentose phosphate pathway, where thiamine pyrophosphate functions as a cofactor in two enzyme parts of that metabolism. It also functions in glycolysis from glucose to pyruvate. And when pyruvate is converted and used in the TCA cycle, thiamine pyrophosphate again functions as a cofactor. Let's turn to thiamine deficiency and its consequences. So impaired absorption is actually fairly common. Alcohol is the most well-known reason for impaired absorption, but conditions that disrupt nutrient absorption also are a cause of thiamine deficiency. And this can include Crohn's disease, pyloric stenosis, peptic ulcers, chronic diarrhea. You can also get deficiency through impaired storage and increased use or overexcretion. So thiamine is stored in the liver, and end-stage chronic liver disease is associated with decreased storage ability. You can also have excess use through things like hyperthyroidism or rapidly growing tumors, which deplete the body stores. You can also have increased excretion through hemodialysis or peritoneal dialysis, or through the use of diuretics. In terms of the symptoms that we see, early on we see fatigue, irritability, poor memory, sleep disturbances, abdominal pain, and thiamine deficiency has historically been classified into several different types. We have wet beriberi, which is high output CHF. We have dry beriberi, which is going to be the focus of this presentation, with Wernicke's encephalopathy transitioning to Korsakoff syndrome if it's not treated. There's also peripheral neuropathy. We also see gastrointestinal beriberi, which is abdominal pain, nausea, vomiting, and lactic acidosis. And Wernicke's encephalopathy is frequently undiagnosed, and if it's untreated, it progresses to Korsakoff syndrome. In terms of the pathophysiology of neurological damage in Wernicke's encephalopathy and Korsakoff syndrome, there are several hypotheses. One is lactic acidosis, and this relates back to where thiamine pyrophosphate functions in various biochemical pathways. And you can see here, if you have a deficiency in thiamine pyrophosphate, you get a buildup of pyruvate, which converts to lactic acid, and this can result in neurological damage. Thiamine deficiency also creates disruptions in the blood-brain barrier, which exposes neurons to toxins, circulating cytokines. There's also neuronal cell excitotoxicity through the buildup of glutamate. There's inherent inflammation, and there's low levels of intracellular ATP. And this is because the TCA cycle is disrupted without thiamine pyrophosphate as a cofactor here. And we know that the heart and brain are organs that are heavily ATP dependent. How about the diagnosis of Wernicke's encephalopathy? Well, traditionally, as we all learned in medical school, there's the classic triad of ataxia or gait disturbances, cognitive dysfunction, memory impairments, and eye movement abnormalities. One or more of these classic features is highly suggestive of Wernicke's encephalopathy. But only 16 to 33% of cases display all features, and 19% of patients meet none of the original triad described. So in practice, we more often use the Kane criteria. These are the operational criteria to be used in clinical practice, trying to look for Wernicke's encephalopathy. And the addition of dietary deficiency increases the likelihood that you will pick up Wernicke's encephalopathy. So the four criteria in the Kane criteria are dietary deficiency, ocular motor abnormalities, cerebellar signs, and mild memory impairment. Two or more of the following of these is 94% sensitive and 99% specific. In addition, there are lots of other associated features, and in delayed or severe cases of Wernicke's encephalopathy, we can see tinnitus, hearing loss, catatonia, and even coma. The prevalence is wide based on the study that you look at, between 0.4 and 2.8% of the population, frequently seen in patients with alcohol use disorder. And we may be missing as many as 90% of cases based on post-mortem analyses. Alcohol use is more common in males as the etiology of Wernicke's encephalopathy, and in females, Wernicke's encephalopathy is more seen from non-alcohol related causes. So let's look at those non-alcohol related causes. So there's gastrointestinal causes. Pyloric stenosis, we don't really see in the adult world any longer because of its surgical correction in infancy, but this was one of the 3 original cases described by Karl Wernicke in 1881. And it reminds us that the GI etiologies of Wernicke's encephalopathy should be on the differential. So there's chronic gastritis, Crohn's disease, diarrhea, recurrent vomiting, colon cancer, or post-surgical causes. There's also psychiatric causes. We talked about alcohol use disorder, but also eating disorders, globus hystericus, schizophrenia, depression, catatonia, also systemic diseases, thinking about those increased losses, renal failure and dialysis, HIV, AIDS, hyperthyroidism, diabetes, genetic abnormalities. But then drugs can also contribute to thiamine deficiency, including PPIs that inhibit absorption, diuretics that increase excretion, chemotherapy, and even TPN if they don't think of supplementing the TPN with thiamine. There's also social causes that can increase likelihood of malnutrition leading to thiamine deficiency, homelessness, poverty, patients who are incarcerated or institutionalized. Looking at alcohol use disorder, 2 of the 3 original 1881 cases were in alcoholics. And many clinicians continue to associate Wernicke's encephalopathy with alcohol use disorder. So alcohol use disorder, we see poor nutrition. And then in addition to the poor nutrition that's inherently part of alcohol use disorder, alcohol itself directly inhibits the absorption of thiamine in the GI tract. Alcohol itself is not thought to be the neurotoxic pathophysiological cause of Wernicke's encephalopathy and Korsakoff syndrome. It's actually the thiamine deficiency that is a result of chronic alcohol use. And end-stage renal disease, liver disease, as we talked about, decreases storage ability. We also see low magnesium levels, which impairs thiamine's activation. And we want to utilize higher doses of IV thiamine and always prophylactic supplementation when we're treating patients with alcohol use disorder. And many studies show that alcohol use disorder induced thiamine deficiency is one of the most frequent causes of Wernicke's encephalopathy converting to Korsakoff syndrome. Bariatric surgery. So over 500,000 bariatric surgeries occur annually. I think this is 2017 or 2018 data, and it's trending towards a younger population for those surgeries. This results in decreased intake, which can contribute to thiamine deficiency, but also reduced absorption because there's less intestinal lumen space for thiamine to be absorbed. There's also a reduction in surface area. There's high rates of vomiting post-procedure, which increases deficiency. And deficiencies can even occur in newer procedures, not just the original Roux-en-Y. Cancer, GI cancers also increase to excessive thiamine utilization due to rapidly growing tumors. And in a study of 45 GI cancer patients, 4% of the patients had signs of Wernicke's encephalopathy on discharge, but at the 6-month mark, 90% of them did. How about critical illness, septic shock, and delirium? Thiamine deficiency may be present in 11 to 70% of critically ill patients in the ICU. There's a number of recent studies over the past few years looking at thiamine, steroids, and ascorbic acid for the treatment of septic shock in the ICU. Many of these are controversial, and the signal that may be present in those studies may be undiagnosed Wernicke's encephalopathy in patients responding to thiamine. There may be a positive effect of using high-dose thiamine in delirium in the ICU. Although the data is mixed, there is a signal for decreased delirium incidence, but mixed data on reduction in mortality and morbidity. COVID-19 that we've all seen recently is a state of hypercatabolic state, increased cytokine storms, frequent use of dialysis, and PPIs can all increase likelihood of thiamine deficiency. We also see increased thiamine deficiency in other hypermetabolic states. Diagnostically, we want to check for thiamine levels. Not everybody does this, but you can do it. It should not delay treatment, however. The cost is low, $13 to $91, based on a quick search of MD Save. Less frequently, blood transketolase. This was used more commonly in the past, used as kind of a surrogate marker of thiamine deficiency. This may guide treatment duration. If you do diagnose delirium, you think Wernicke's encephalopathy is common, you're using high dose thiamine, and you're waiting for your lab to come back before you discontinue or wean off the high dose thiamine. But checking the blood level may also allow you to attribute any clinical benefit you see to the thiamine that you're using. Neuroimaging is also used. Results vary widely depending on the etiology. Typical lesions are seen in 58% of patients. The sensitivity is 53%, but specificity is 93%. A lot of the issue is that imaging is obtained after thiamine is administered, and you may have reversal of those abnormalities with thiamine used. And so you may not see the abnormalities if you get the imaging late. Here are some examples of neuroimaging findings in thiamine deficiency. We see T2 signal changes in the periventricular regions of the thalamus and hypothalamus. We see reduction in size of the cerebellum and mammillary bodies, medial thalami damage, which is more associated with Korsakoff syndrome, which is the most frequent etiology of conversion from alcohol use disorder. And here's a close-up of mammillary body damage. In terms of treatment, prevention and prophylaxis is where we want to put our energy. So thiamine is fortified in foods. Bariatric surgery patients are supposed to be taking thiamine indefinitely. And in patients who are admitted who have alcohol use disorder, they should be given IM or IV thiamine. Faster time to treatment means less chance for permanent neurological damage. So time is brain, just as in strokes, it's also in thiamine deficiency and Wernicke's encephalopathy. In a study of 17 cases of Wernicke's encephalopathy, those who did respond to thiamine, the time to initiation of treatment was about 4 days, while those who did not respond to thiamine, time to initiation of treatment was 61 days. Time from initiation of treatment to resolution of symptoms was 2.4 days for those who responded, and sometimes response can be seen within hours. How do we diagnose, or how do we dose thiamine? We want to use intravenous parenteral thiamine. Oral supplementation is insufficient in patients who are deficient. It's important because many of the causes and etiologies of thiamine deficiency are because of impaired absorption. This medication using IV thiamine is very safe. Rates of anaphylactic shock are exceedingly rare. Dosing and timing is important, and we have different governing bodies recommending different doses. British recommendation is 500 milligrams IV TID for 3 days. This is the dose and timing that is most frequently used in the United States. We do want to make sure we're using it 3 times daily if we have diagnosed Wernicke's encephalopathy due to the short half-life. We want to consider ordering the medication stat and not allowing routine use. Routine use may delay that initial administration of thiamine for several hours or up to a day. We want to supplement low magnesium levels, and we really want to consider empiric treatment as much as possible. There's not a lot of concern about overuse. If you are overusing thiamine, IV thiamine, the main costs that I would see would be the price tag and potentially overutilization of the supply. And recently, within the last year or two, we have had some shortages of IV thiamine, but there is no toxicity. Korsakoff syndrome is the most feared outcome, and this is seen when you do not treat Wernicke's encephalopathy, and it's a syndrome of permanent neurological damage, psychiatric symptoms. About 30 to 80% of patients who survive Wernicke's encephalopathy will go on to develop Korsakoff syndrome, and most of those patients are in the chronic alcoholics. Wernicke's encephalopathy can be treated and diagnosed, but it needs to be done early. Korsakoff syndrome is largely considered irreversible, but the rates of irreversibility may have been overstated in early literature. The initial presentations of Korsakoff syndrome were described in patients with alcohol use disorder. And it wasn't linked to thiamine and Wernicke's encephalopathy until the 1950s. The incidence and prevalence of Korsakoff syndrome is unclear. There's no universal diagnostic criteria. Thiamine deficiency and not ethanol neurotoxicity is the pathophysiological etiology of Korsakoff syndrome. And we think that not as much the mammillary body damage, but actually the medial thalami damage is what is the histopathological finding most commonly seen in Korsakoff syndrome. And we see global amnesia, confabulation, apathy, executive function deficits, and confusion. And behavioral symptoms are very common as well. We see irritability and euphoria early on, and then apathy and more confusion later on. Psychosis can be seen, and we, in the past, some would actually describe this as Korsakoff psychosis. In terms of treatment, so structured living environment, alcohol abstinence, cognitive rehabilitation, and there's very weak data on a trial of memantine or donepezil to try to reverse some of the deficits. In conclusions, thiamine, it's critical in multiple biochemical pathways and energy metabolism. Deficiency is a result of malnutrition, decreased absorption, increased utilization and excretion, and impaired storage. It's more than just alcohol use disorder. It's seen in cancers, HIV/AIDS, surgeries, GI processes, and psychiatric illnesses. Wernicke's encephalopathy is a reversible short-term consequence of thiamine deficiency if it is caught early, and Korsakoff syndrome is a long-term consequence if we do not catch it early. Using the classic triad of Wernicke's encephalopathy, we may underdiagnose it, and we want to use the operational Kane criteria. Laboratory testing and neuroimaging can be helpful, but should never delay treatment. And we should consider prophylactic treatment, early initiation of high-dose IV thiamine, which is key to reducing morbidity and mortality of thiamine deficiency. So administer it quickly, intravenously, and use it until benefit of treatment appears to plateau. Here are my references, and I've highlighted a few that I think are most key and relevant. Thank you for your attention, and please email me with any questions. Thank you.
Hello, I'm Sharif Tanius, and I'm a consultation-liaison psychiatrist at the Carilion Clinic in Roanoke, Virginia. And I'm going to talk about vitamin B12 today. So, brief snapshot. I'm at a large tertiary referral hospital in Southwest Virginia with about 700 beds. And right now on service, we've got a 68-year-old male with delirium after back surgery, an 81-year-old female with major neurocognitive disorders and behavioral disturbances who's on chronic PPI therapy, a 54-year-old male with major neurocognitive disorder due to a TBI and chronic alcohol use, and a 61-year-old male with delirium due to alcohol withdrawal. And, what do all these patients have in common? Low B12. And, this is pretty consistent with the literature in terms of about 25% of the patients on our service on routine investigation will have low B12 levels. And that's pretty consistent with other studies. A brief outline I want to talk about today is the biochemistry of B12 and B12 deficiency, some of the epidemiology related, the clinical impact of B12 deficiency, how to test and interpret that testing results, some of the neuropsychiatric effects, as well as treatment options. So going on to the biochemistry, B12 is an essential cofactor in two processes in the human body. The first will be the conversion of methylmalonic acid and methylmalonyl-CoA to succinyl-CoA, and then the conversion of homocysteine to methionine. That one, of course, also dependent on the presence of folic acid. When there is a B12 deficiency, this ends up elevating levels of methylmalonic acid and homocysteine, which ultimately drive a lot of the pathophysiologic consequences of this deficiency. Some of the main non-neuropsychiatric clinical manifestations include hematologic ones, neurologic, and cardiovascular ones. As far as hematologic complications, the most commonly known is megaloblastic anemia or pernicious anemia, as well as pancytopenia. Neurologic includes peripheral neuropathies, paresthesias, as well as demyelination seen often in subacute combined degeneration, which is degeneration of the posterior and lateral columns of the spinal cord, as well as cardiovascular with increased risk of heart attacks and strokes thought to be related to elevated levels of homocysteine. So how does somebody get deficient in B12? Well, there's a number of different ways, typically related to either a intake problem, so a nutritional deficiency, or impaired absorption. And there are some other causes as well. So starting with nutritional deficiency, this is often seen in geriatric populations, folks with limited dietary variety, people who are unfortunately with lower socioeconomic status who may have limited access to a variety of different foods, as well as sort of induced deficiencies, things like eating disorders. Then in terms of impaired absorption, classically the most common would be a lack of intrinsic factor seen in pernicious anemia. An intrinsic factor is something that will bind to the B12 in the GI tract and allow its that complex to be absorbed in the terminal ileum. There's also an inability to liberate B12 from the food that is ingested. This is often seen in situations where there is low gastric acid, which can be due to atrophic gastritis or structural or changes to the GI tract in gastric bypass, but also can be seen in medications and substances which block the absorption of B12, including metformin, alcohol, but also again with chronic acid blocking medications can limit the ability for B12 to be liberated from food. There are other causes, bacterial infections and genetic abnormalities, which can contribute to the inability to utilize B12 that is ingested. The true incidence and prevalence of B12 deficiency is somewhat unknown. We generally see groups with poor nutrition and lower socioeconomic status at the highest risk. In some studies looking at strict vegetarians and vegans, wide varieties of patients, 21 to 85% have some level of B12 deficiency. In geriatric patients, up to 15% in one study on sort of routine investigation. The issue with B12 is that there are about 2 to 5 milligrams stored in the body at any one time, with daily loss of about 0.1%. So this is a deficiency that takes years to develop with either poor nutritional status or some other problem going on that's impairing its absorption. What's interesting is that the neuropsychiatric complications can often be seen before the hematologic or neurologic, and 40% of cases in one series, those neuropsychiatric complications develop before the hematologic. In terms of testing, the serum B12 level is what is typically used. Most labs are going to be slightly different, but generally a level greater than 200 is considered normal. In looking online, it costs about $35 for a serum B12 test. There are some other associated tests that may be worth considering, including a CBC with differential to look at anemia and MCV, but also methylmalonic acid and homocysteine, as these will both be elevated in situations where B12 is deficient and you're having blocking of that conversion of those two products. An older test is the Schilling test, which was historically used for pernicious anemia, which was actually developed by Robert Schilling in 1953. However, this test is not widely used anymore. However, it was one that took radio-labeled B12 and orally and injected non-radio labeled and looked at the excretion fraction, and then repeated again with the addition of intrinsic factor if that was abnormal, to look for that absence of intrinsic factor that would then allow for absorption of B12 orally. Oftentimes you may also get a B12 level and you get a really, really high level, which would initially think, okay, everything is fine. But unfortunately, that elevated level, extreme elevated level of B12 in the absence of known supplementation can be evidence of systemic disease, commonly seen in hepatic and renal disease, malignancies, also heavy alcohol use. And it's thought to be related to the deposits of B12 being liberated with hepatolysis or reduced elimination through renal or hepatic pathways. In these instances, it's worth checking for a methylmalonic acid and homocysteine for evidence of a functional deficiency where the body is unable to utilize the B12 that's being found in the serum. So the neuropsychiatric pathophysiology is really related to those byproducts being elevated of methylmalonic acid and homocysteine. Historical cases have noted perivascular degeneration and myelin degeneration as a result of B12 deficiency, and it's similar to, on MRI, to other diseases that impact myelination, such as MS. There are several mechanisms that have been used to describe that neurocognitive dysfunction related to it, and that's really thought to be related to the inability to produce methionine for SAMe synthesis. And SAMe is a major methylator for phospholipids, neurotransmitters, proteins, and DNA. In elevated homocysteine, it's thought to be neurotoxic through the creation of homocystic acid. That is an endogenous NMDA agonist, which can be excitotoxic. Also, homocysteine can lead to cerebral microvascular disease as it impairs clotting within the vascular endothelium, and that actually increases the risk of vascular dementia. Again, symptoms may precede the hematologic sign by months or years. So again, just because a patient doesn't have an elevated MCV doesn't necessarily mean that there isn't a case to look for a B12 deficiency. Looking at delirium, it's one of the most frequently recognized symptoms of B12 deficiency. There are multiple cases and historical references that exist to this relationship. It's been implicated both individually as the sole cause of delirium, as well as in conjunction with other medical issues. In one study looking at patients undergoing CABG with matched controls, the group with B12 deficiency had a much higher rate of delirium postoperatively, and the delirium severity measured on the DRS-R98 was greater in those with B12 deficiency, and was independently, B12 deficiency was independently associated with delirium in that study. Dementia and neurocognitive disorders, B12 deficiency is frequently thought of as a reversible cause of cognitive changes, though there is limited evidence for supplementation when B12 levels are normal and no real benefit of cognitive enhancement. However, it's frequently found in those with dementia, though it isn't always reversible. And generally speaking, the longer the disease has progressed, the less likely that it's going to be responsive to treatment. In one study, they found significant improvement in cognitive dysfunction in 11 out of 18 patients, but their symptoms lasted for less than 1 year. Whereas in those patients in that study where their symptoms were going on for longer than a year, had little improvement even with the addition of B12 supplementation. Psychosis is another manifestation of B12 deficiency, sometimes even noted to present with catatonia. And this is often thought to be related to the neurotransmitter abnormalities, impaired synthesis, the direct neurotoxicity of hyperhomocystinemia, and then also possible demyelination, autoimmune demyelination. Again, with all of these neuropsychiatric complications, these patients can lack the hematologic or other neurologic signs. So it's important to consider that in your differential, especially when their presentation is somewhat atypical, either from an age standpoint or other clinical features. Depression is commonly thought of with B12 deficiency, although it's unclear whether that is in fact causative. A number of studies have noted that depressed patients tend to have lower B12 levels, but that's also seen in geriatric populations who are at risk of B12 deficiency for a variety of other reasons. There are higher levels of B12 deficiency amongst hospitalized patients with mood disorders. There is one small randomized trial without benefit of B12 supplementation for depression in the absence of deficiency, and then other studies with supplementation as an adjunct that were positive. So given the known pathophysiologic impact of B12 deficiency on neurotransmitter synthesis, myelination, there likely is a relationship, although more research is needed in long-term studies. So how do you treat B12 deficiency? Traditionally, it's been thought to only use parenteral, especially when malabsorption is the primary cause. However, about 1% of B12 is absorbed orally, independent of intrinsic factor or even a functioning ileum. A Cochrane review looked at oral versus parenteral B12 and found that high-dose oral was equivalent or even superior to parenteral, easier and cheaper, and they would be using 2,000 milligrams orally daily versus 1,000, I'm sorry, not milligrams, micrograms versus 1,000 micrograms intramuscularly at intervals. And this bottle is about $27 for 400 tablets of 1,000 micrograms, although they do create larger quantity tablets of even up to 5,000 microgram tablets. So kind of in conclusion, the routine evaluation of B12 would be most indicated in patients at risk. So that's medically frail, malnourished, geriatric patients, folks with gastrointestinal anatomical changes, whether surgical or otherwise. And that ends up being most of the patients on an inpatient consult service. And considering that supplementation should be encouraged in patients even when their levels are in that low normal range of sort of 200 to 600. It may even be worth checking a methylmalonic acid and homocysteine if B12 levels are normal, but you have strong clinical suspicion that a B12 deficiency may exist, or they're not responding to treatment as you would have otherwise expected. Consider using high-dose oral supplementation, which is well tolerated, cheap, and effective, and patients tend to be able to continue that at home. However, parenteral supplementation should be done in cases of severe disease, lack of PO access, and it can help with adherence in some patient populations. Ultimately, there's very low risk to supplement with B12 and a lot of potential benefits to treat. Here are my references. Thank you. And now Dr. Holmes will talk about folate.
All right, I'm Dr. Emily Holmes. I'm a consultation liaison psychiatrist at Indiana University School of Medicine. Today, I'm going to be talking about folate. This was particularly interesting to me because I have noticed in my own practice that I've had quite a bit of variability in whether I recommend checking folate levels or not. I went from checking folate levels pretty commonly in delirium and cases of cognitive impairment and found very few low levels. So then I stopped checking it altogether. And I was hoping to come up with a practice that was more evidence-based and rational. So the questions that I had going into this research were whether folate deficiency actually is a common problem. If I have a patient with a normal B12 level, should I also be, could I be concerned for folate deficiency in that patient? In the same way, if a patient does not have evidence of anemia or macrocytosis, should I still be concerned for folate deficiency? What is the role of folate in delirium, dementia, and depression? When should a folate level be included in the workup? And how much does a folate level cost? So to take a step back, folate is an essential vitamin, which means that we can only obtain folate through our diet. It is found in green leafy vegetables, in beans and legumes. And the synthetic form of folate is folic acid, which is found in supplements. So after we consume folate or folic acid, our liver stores about 5 to 10 milligrams of folate, and this level can be depleted in weeks to months. Folate is essential for synthesis of DNA, RNA, and neurotransmitters. In 1998, fortification of grains and rices with folate was instituted in the United States, and this is followed in other countries since then. So this is a main source of folate in the American diet. Folate deficiency symptoms can include symptoms of anemia, such as shortness of breath, fatigue, cognitive impairment. Symptoms in the GI tract include oral ulcers, and then neuropsychiatric symptoms, including depression, insomnia, cognitive impairment, psychosis. It's important to note that there is no sort of longitudinal timeline of symptoms of deficiency. So a patient could present with the neuropsychiatric symptoms first without evidence of anemia or GI symptoms. There are a number of risk factors for folate deficiency. This includes increased requirements, especially in pregnancy, hemolysis, loss through hemodialysis, patients with bone marrow, undergoing bone marrow transplant, through decreased intake, such as in eating and feeding disorders, decreased absorption, which is largely through malabsorptive syndromes, and increased metabolism, particularly by medications that are relevant to us, including the mood stabilizers. Alcohol use disorder is a particular risk factor for folate deficiency, and that's because alcohol impairs absorption of folate at multiple levels. Patients with alcohol use disorders might have reduced intake, impaired absorption through the GI tract, impaired uptake in the liver, increased metabolism of folate, and increased secretion through the kidneys. When we're considering folate deficiency, we can look at the hemoglobin and hematocrit, as well as the mean corpuscular volume, or MCV. Like vitamin B12, folate is considered a macrocytic anemia. So often you'll have evidence of anemia with macrocytosis. However, that is not universally found in cases, and so it still can be worth checking a serum folate, even if those levels are normal. And serum folate levels cost about $10 to $50, depending on the lab. There's also another test for folate levels called the red blood cell folate. This test is a little bit more expensive, and it measures folate in the cell itself. But generally the serum folate is sufficient for an initial evaluation. And so red blood cell folate is not recommended, at least at first pass. So since enrichment of folate in 1998, there's been an interest in measuring rates of folate deficiency within the population. So one study that occurred over 10 to 11 years in Boston looked at a large population of patients who had folate levels drawn, and found that only 0.056% of those patients had a deficient level. Though the cost of the individual test is low, at that prevalence of deficiency, the cost as a whole is pretty significant, with cost of about $3,600 per deficient test and $36,000 of reimbursement per deficient test. Hospitalized patients who presumably would have more risk factors for folate deficiency have had rates of folate deficiency ranging from about 0.16% to 13% in different countries. All of these countries listed have fortification of folate in the diet. It's important to note that in all of these studies, these are retrospective studies where folate levels were drawn. And so this was looking at prevalence of folate deficiency in people that presumably had some reason to have the test drawn. So this might actually overestimate the prevalence of folate deficiency in outpatients and hospitalized patients. So turning to look at the association between folate and depression, there have been mixed studies that have shown low folate associated with depression. In addition, low folate has been associated with poor response to antidepressants. However, in systematic reviews, there's been no clear evidence that adjunctive folic acid helps with depression outcomes. So taking a deeper look at this, folate and folic acid are converted in the body to 5-methyl tetrahydrofolate, also known as L-methylfolate. This conversion is coordinated by the MTHFR gene. There are some people that have polymorphisms in this gene that make it more challenging for them to convert folate and folic acid into the active form L-methylfolate. So because of this, there has been interest in research at looking at downstream substances to see if those might help in treating depression. So a synthetic form of L-methylfolate called Deplin has been studied, as well as SAMe. In the CAN-MAT guidelines, SAMe is considered a second-line adjunctive treatment for mild to moderate depression. L-methylfolate is considered a third-line adjunctive treatment. Turning to cognitive impairment. So as noted by Dr. Tanius, low folate, like low vitamin B12, is associated with high homocysteine levels, and high homocysteine levels are associated with cognitive impairment and risk of vascular and Alzheimer's dementia. However, the systematic reviews have shown that though supplementing with folic acid can lower homocysteine levels, it does not consistently improve cognitive outcomes, with the caveat that some people may experience slowing in cognitive decline with supplementation. There's actually very little recent research about folate deficiency and delirium. There was one study that showed that there was no relationship between folate level and risk of delirium after cardiac surgery. So I'm going to pivot for a moment. One of the places where folate research is very clear is that mothers who have folate deficiency are at risk of having babies with neural tube defects, and that supplementation with folic acid can prevent neural tube defects. And this was part of the motivation for fortifying grains and rices back in the 90s. Because there is this strong recommendation, the American College of Obstetrics and Gynecology and the U.S. Preventive Services Task Force recommend that all women who are capable of becoming pregnant take a supplement of 400 to 800 micrograms daily of folic acid. Of note, they don't make standard recommendations for testing, and in my experience, folate level is not sort of a routine part of testing in pregnant women. So in this particular case, where we have a strong association between supplementation with folic acid and prevention of adverse effects, they're not recommending testing and just instead recommend standard supplementation. So if one wanted to supplement with folic acid, again, 400 to 800 micrograms is recommended for prevention of neural tube defects in pregnancy. For high-risk groups, 1 milligram daily is recommended. This is what we often see in patient supplementation for patients with alcohol use disorder. And treatment for folate deficiency can be 1 to 5 milligrams daily of folic acid. Though generally the body is good at excreting excess folic acid, and there's little risk due to high levels of folic acid, there is the potential risk that over-supplementation with folic acid could mask B12 deficiency and result in adverse neurological outcomes. So this is a concern with over-treating with folic acid. So based on the epidemiological studies and based on the high cost for abnormal levels of folate detected, there has been a push towards no longer testing for folate deficiency. In addition to what we've already noted, there's been poor consensus on the appropriate cutoff for folic acid or folate levels. In addition, a high folate meal can produce a false negative result. There's little evidence in delirium, dementia, and depression that supplementation can improve outcomes. And sadly, even when patients have been tested and found to have folate deficiency, they often are not treated or supplemented with folic acid. So based on all of this evidence, I think one approach, and the one that I'm going to take moving forward, is to not universally test. Rather, I can just supplement patients at risk for deficiency with a standard multivitamin. I would say 1 milligram or less per day, checking a B12 level if I'm concerned that they could also have a B12 deficiency. And when I also recognize that there are cases where we just don't know what's going on. We have unexplained symptoms. We have a patient that's also at high risk for folate deficiency. I think it still is reasonable to check, even if the patient doesn't have anemia, macrocytosis, or other symptoms of folate deficiency. Again, the test is individually inexpensive. It becomes expensive when we're looking at an entire population of patients. These are my references. And next, we're going to hear from Dr. Caitlin Adams.
So I'm Caitlin Adams. I'm a psychiatrist in Salem, Massachusetts, and I'm going to be talking about vitamin D. I'm going to start with a brief outline about what I'm going to cover in this particular presentation. I'm going to start with a brief slide of the biochemistry of vitamin D. I'm going to talk about why it's important in general, and then specifically, since this is a psychiatric focused lecture, I'm going to talk about the neuropsychiatric manifestations, including dementia, delirium, depression, anxiety, and psychosis. I'm going to talk about how we monitor, when we monitor, and then how to treat. So I'm going to start with two brief cases. Vitamin D is interesting. There's really most patients have mild or no symptoms at all. So it's kind of hard to pinpoint a specific clinical picture. So I gave two cases. One is a 75-year-old female who carries a diagnosis of schizophrenia and is also noted to be obese. She was admitted to a state inpatient psychiatric facility 6 months ago with persistent psychosis despite antipsychotics. Her vitamin D level was checked and found to be less than 10 nanograms per milliliter. She was started on replacement, but shortly after diagnosis, she fell and broke her femur. And then the second case is a 30-year-old female who carries a history of depression, also Hashimoto thyroiditis. Her TSH is currently normal. She was admitted with treatment-resistant depression. Her outpatient team was recommending an evaluation for ECT, and her vitamin D was found to be below 12 nanograms per milliliter. Her depression improved with a change in her antidepressant and with vitamin D supplementation. So the kind of takeaways from these cases is patients who are on antipsychotics, who are obese because vitamin D is a fat-soluble vitamin, particularly patients who were admitted to facilities for a long time, be it a state inpatient psych hospital, an acute inpatient psych hospital, or even on the consult service, and are not getting sunlight, are at risk of becoming vitamin D deficient. So as far as the biochemistry, vitamin D is mostly produced from our own skin. So you can get it from our diet. That's a pretty low, it's mostly coming from our skin. So there's 7-dehydrocortisol in our skin that's broken down by sun, so UVB light, into pre-vitamin D, which then goes to the liver, where it's processed into hydroxy vitamin D. That's the primary vitamin D that's floating around in our serum. It's further processed by the kidneys. And here is where the belief is that vitamin D, even the term vitamin D, is a bit of a misnomer because vitamin D acts like a steroid. So the product from the kidneys is kind of what goes out to the rest of our body and starts participating in transcription and participating in bone resorption. So pulling calcium into our bones, pulling calcium out of our intestines. Vitamin D also has an inhibitory effect on the parathyroid glands. So here, if the parathyroid is kind of out of control, it's going to break down bone. So it's kind of this feedback process. So why is vitamin D important? We all know it plays a role in musculoskeletal health. So in severe deficiency, which again is quite rare, it can cause rickets or osteomalacia or even osteoporosis. It can increase risks of falls and fractures like the first case I presented. It plays a role in cardiovascular health as well. So there's a belief that it activates the renin-angiotensin aldosterone system and might contribute to or worsen CHF. It can result in impaired systolic or diastolic function. It can lead to MIs, hypertension. There's also been some buzz about vitamin D since the onset of COVID. Vitamin D does have a receptor on immune cells. Does having sufficient vitamin D protect you from COVID? I think the jury is still out, but it's worth considering. And then there are neuropsychiatric beliefs about vitamin D. Does it contribute to or worsen dementia, depression, anxiety, psychosis? What role does that play? What's interesting about vitamin D is a lot of the studies, particularly the psychiatric studies, are not great studies from the standpoint of they don't really meet criteria for a nutritional study. So they don't necessarily include patients who are completely depleted of vitamin D. I also think it would be difficult from an IRB standpoint to get it approved it's tough. If you've got a patient with really low vitamin D, are you just going to give them placebo when you know that it has bad consequences later? A lot of the studies too, which I'm going to kind of dive into here shortly, have really low sample sizes. So the N's are very small. I think it's difficult to make conclusions. And I think a lot of the studies conflict other studies. So it's difficult really what take-home message we take away from this. So epidemiology, it's estimated that 1 billion people worldwide have either insufficiency or deficiency. 40 to 100% of elderly US and European men and women living in the community are vitamin deficient. And people who are at high risk of vitamin D deficiency are children, young adults. The elderly are also at risk because their skin is doing less of that making of the vitamin D. It's less efficient. People who live at high latitudes or they spend little time outside are more likely to be deficient. Most studies say that if you spend at least 15 minutes outside a couple times a week, you should get plenty of vitamin D. But now that we're all wearing more sunscreen, that would drive down our vitamin D production. And then skin pigmentation plays a role too. So in a study in Boston, 52% of Hispanic and Black adolescents had a vitamin D deficiency, and 48% of white pre-adolescent girls in a study in Maine had deficiency. So I think most of us are probably at risk of being vitamin D deficient. So what classifies as vitamin D deficiency versus insufficiency versus sufficiency? There was no great consensus on this. So you'll see different numbers, different places. The most common for a deficiency would be less than 20 nanograms per milliliter. Insufficiency would be 21 to 29, and sufficiency would be above 30. What we know is that anything below 20 is bad for our skeletal health. So I think that's where most associations cut it off, that below 20 is a problem. So let's shift gears and talk about kind of the neuropsych manifestations. Again, to have a pretty severe vitamin D deficiency is rather rare, and people who are vitamin D deficient aren't going to present with a triad of symptoms. It's pretty mild. So I'm going to talk about what proposed role vitamin D perhaps has in dementia, delirium, depression and anxiety, and then psychosis. So starting with dementia, there are multiple meta-analyses and systematic reviews that show vitamin D deficiency and dementia have some sort of temporal relationship. We know that there are vitamin D receptors in the brain, many places, the hippocampus, the substantia nigra, which we know plays an important role in dopamine production. And then we know that vitamin D, like I mentioned before, oftentimes acts as a steroid. So some people think the term vitamin D is a bit of a misnomer because it's playing a role perhaps in transcription. So a couple of preclinical studies that I found were talking about being able to turn off vitamin D receptors in rat brains and what that resulted in. So in this first Gezin study, they disrupted the functioning of vitamin D receptors in rats, and it resulted in increased amyloid pathology and amyloid beta production. And then the second study, it showed that if you give vitamin D supplementation, production of amyloid beta can be slowed. So perhaps there's a role of vitamin D in the onset of dementia. As far as kind of what does supplementation do, or do we know are people with dementia more likely to be vitamin deficient? Here are some studies, one meta-analysis. had almost 2,000 participants with dementia. And the conclusion of this study was that there's a lower risk of dementia if your serum vitamin D level is above 25. Another meta-analysis, the second one, was focusing on the role of diet in the risk of dementia. So people who eat more of a Mediterranean diet, higher in folic acid, and low vitamin D was strongly associated with impairment in neuropsychological function. And then the next one, Roy, was a kind of a review of multiple preclinical and clinical studies, and there were conflicting findings. So the first one said maybe vitamin D helps in dementia, maybe it doesn't. Another study showed that it is associated with impaired neuropsychological functioning. And then in the last one, people with dementia were found to overall have lower roles of vitamin D. So conclusion for vitamin D and dementia is vitamin D deficiency is probably bad for our brains. Supplementation probably helps, but I don't think it's as simple as vitamin D deficiency leads to dementia, or just because you have dementia, you are vitamin D deficient. So delirium, there's been some studies about whether or not vitamin D plays a role in delirium. I think it's an interesting question because a lot of times when patients are delirious and in the ICU, they have a high burden of things going on. So they might have hemodilution, they might have impaired liver processing, so they might not be producing enough vitamin D. There is a trial that is recruiting currently that is going to provide important information about the efficacy of high-dose vitamin D in critically ill patients with severe vitamin deficiency. So that's going to be a randomized placebo-controlled double-blinded trial. The second study was a Mendelian randomization genetic analysis to try to remove confounding factors to see if there is causation. A pretty big N there, 351,000 vitamin D deficiency patients. And they felt like vitamin D deficient perhaps did lead to an increased risk of dementia. And then they also concluded that it wasn't just limited to the deficient group, that people who kind of fell in that middle range, the insufficiency levels, 25 to 50, were also at an increased risk of dementia. And then the genetic analysis part of this study, participants carrying more vitamin D increasing variants had a reduced likelihood of incident delirium diagnosis. Two more kind of studies looking at the role of vitamin D in delirium, another Mendelian randomization. It supports a causal role of vitamin D in incident delirium. Trials of low vitamin D levels for prevention of delirium are needed. So this one argues that we probably should be checking and replacing vitamin D in patients with delirium. The next study was interesting because it was a retrospective analysis looking at patients who were diagnosed with delirium and whether or not, one, vitamin D was checked, or two, it was supplemented. So only 71 of over 1,000 delirium patients, which is 5.8% of patients with delirium, had vitamin D tested. And of that 5.8 that were tested, 66% had insufficiency or deficiency. So again, the data is a bit mixed, and we don't really know about the causal role. Perhaps from these Mendelian randomization models, it might. And I think too, we'll talk about who to test at the end, kind of towards the end, but I think if you're going to be testing other vitamins, you might as well throw vitamin D in, because we know that there are vitamin D receptors all over the body. And I would argue it's probably better to be treated than not treated. So what role does vitamin D play in depression and anxiety? A lot of these studies, it was interesting because it was patients who were already depressed and they supplemented the vitamin D. It's not so, I don't know that we can really answer the question of, does a normal level of vitamin D prevent you from becoming depressed or anxious? So the first study, a Mendelian randomization study, it did not reveal a causal role between vitamin D level and major depressive disorder. The next one was a cross-sectional study, and this one looked at whether or not vitamin D played a role in specific domains of depression. So they actually found that it did play a role in cognitive domains, but only in men, which the conclusion of this study was, does testosterone also play a role in this? Women with diagnoses like PCOS, who have higher androgen levels, have a higher rates of depression as well. So there might be more to learn about that. And then the last one on this slide was a nested case control and a randomized control study. And it determined that low vitamin D at baseline, patients with low vitamin D at baseline were more depressed than those who had sufficient or high levels of vitamin D. However, they tried to look at supplementation of vitamin D in those who were already clinically depressed, and they didn't really feel like that had any effect on the outcome. The first one on this slide was a randomized placebo-controlled study. It showed that patients over 50 years old without depression at baseline, that supplementation compared to placebo did not result in statistically significant differences in the incidence or recurrence of depression. I want to point out that one limitation of this study was that they only checked a PHQ-9. It was a self-assessment. It was only done once a year. So I think that might throw off the results a little bit. The next study was a cohort study, and it looked at the vitamin D levels. They determined that they felt like it was low vitamin D was associated with the presence and severity of depressive disorders, and that low serum vitamin D was also associated with less favorable course over a 2-year follow-up. And then the last one on this slide, randomized controlled trial, and it said no significant effect of vitamin D replacement on depression symptoms. However, they felt like very few patients in their study had clinically significant depression. So I think we could make an argument that if they had only enrolled very depressed patients, maybe it would have had more of an impact. And then as far as psychosis, we know that patients with schizophrenia have high rates of vitamin D deficiency. There's been a theory of thought that perhaps there's a temporal relationship for those who go on to develop psychosis or schizophrenia. So those who are born in the winter when the sun is out less, geographical locations, those born in urban settings are more likely to have a diagnosis of schizophrenia. So is it because mom is getting less vitamin D during that time? And again, those with schizophrenia have a high rate of vitamin D deficient. So it might lead to them having this diagnosis of schizophrenia. And then once they have the diagnosis, they might also be deficient themselves. So one systematic review said that it probably has a 70% prevalence of vitamin D deficiency in patients with schizophrenia. But I found others that suggest 90% of patients with schizophrenia might have a vitamin D deficiency. There are some studies trying to look specifically on negative symptoms. So this kind of falls back into the, does vitamin D play a role in depression and anxiety? The data here is mixed. So some studies said maybe it helps, maybe it doesn't. As far as supplementation in patients with schizophrenia, this first one was a randomized control, double-blind, placebo-controlled study. And they gave supplementation for 12 weeks. They found that it improved not only positive and negative symptoms, but also had improvement in metabolic profiles. The second study, they gave 300,000 units via IM injection twice within 3 months and didn't see any significant improvement. And then the last one, when they gave 12 months of vitamin D supplementation, they found that patients with schizophrenia who got the supplementation had lower rates of depression and anxiety. I found this study really interesting because they were looking at inpatients. And I know in some states, inpatient psychiatry patients are allowed to go outside, and in some states they aren't. I think arguably any patient admitted to any inpatient unit, so be it medical unit, psychiatric unit, are probably getting less sunshine than they would if they were outside. So this study looked at any new psych inpatients. They gave all of them supplementation for 12 months, and they found that it did increase their serum vitamin D level. What that goes on to show, did their symptoms improve? Did they have less depression and anxiety? We're not really sure, but they found that they had no adverse side effects. So the risk of supplementation was quite low. And again, if we have that many vitamin D receptors in our brain, it's probably good to have sufficient vitamin D to make sure that everything is doing what it needs to do. So who to test, who to monitor. I Googled the test, and Bryce is going to talk about more specific costs of the test at the end of this presentation. But Google says anywhere from $15 to $400. The average cost is about $50. And something else to be mindful of, supplementation is typically an out-of-pocket cost for the patient. So some patients might be able to afford this, no problem. For others, it might be a struggle. On the right, I gave some risk factors for developing vitamin D deficiency. So here, darker skin, increased age, inadequate sunlight exposure, people who wear a lot of sunscreen, long-term hospitalization, so people who have been in the hospital for a long time, pregnancy, any kind of malabsorption syndromes. I would think about people with liver disease, because then you'll have decreased production. Kidney disease, you'll have decreased production, and some medications there at the bottom to be mindful of. When to recheck. So if you do supplement, should you recheck? When should you recheck? If you give a bolus of vitamin D, it's suggested you check after 1 month. And then 3 months after supplementation, the levels should be reflective of the supplementation. So again, it's kind of unclear who best to test. I would probably argue that if you're going to be testing other vitamins, you might as well throw in vitamin D. It's a relatively low cost. I also think we probably all could benefit from vitamin D supplementation. So it's probably better to treat than not treat. and the risk of treatment is quite low. So things, again, to be mindful of here is that obesity can cause deficiency. So it's a fat-soluble vitamin. I always think about how our antipsychotics, when we are prescribing them, are causing obesity. So we might be causing vitamin D deficiency just by giving people antipsychotics and making them gain weight. So think about those things. And then treatment. So how much? 600 international units per day is the recommended daily allowance. If you're going to treat based on age, between ages 19 and 65, 15 minutes in the sun or supplementation is still safe. You probably don't need to supplement, but it's not going to hurt too. So 800 to 1,000 is the recommended dose. For those 65 to 75 or with darker complexion, the recommendation is 800 to 2,000 international units per day. Those over age 75, just because they're less efficient in making the vitamin D, anywhere from 200 to 4,000 is the recommended dose. And those who are pregnant, it's recommended that they take 2,000. How much vitamin D is too much? So one study looked at 600,000 international units per day for several months, and that led to toxicity. So again, I think it's difficult to become toxic. What does that look like? It's going to be hypercalcemia symptoms. So people might feel nauseous, dizzy. They might get kidney stones, but it's pretty hard to become toxic on vitamin D. Do you use vitamin D3 or vitamin D2? So D3 has been found to increase levels more efficiently than D2. D3 happens to be more expensive. I know that we start by a loading dose here in my hospital with vitamin D2, and then we flip it to vitamin D3. Do you give daily or weekly doses? So that doesn't really matter. It's more about the cumulative dose. I think if you have someone who is very deficient, you probably would want to bolus and then go on to doing a daily treatment. And then PO or IM form, so a randomized control study, looked at supplementation, PO versus IM, and it actually showed that the PO dose was more efficient in raising the vitamin D levels than the IM administration. When you go to UpToDate to look up vitamin D, it does say that the IM administration is quite painful. So that's also something to keep in mind. And then if you're going to treat based on level, if the patient is below 12, you would probably give a big bolus weekly for 6 to 8 weeks, and then move to a PO supplementation for 12 to 20, which is kind of in that insufficiency range. It recommends that you give 800 to 1,000 international units and then recheck after 3 months. And if you fall between 20 and 30, then it recommends you just give 800 daily. So in conclusion, that it's important to know that vitamin D receptors are in many places. They're probably on immune cells. They're all over our body, including the brain. Vitamin D deficiency or insufficiency may play a role in dementia, delirium, depression, psychosis, but the data is mixed. There are a lot of conflicting studies. But in conclusion, supplementation is low risk and it can lead to a potential improvement in symptoms. So if it were up to me, I think we should all be on vitamin D supplementation. So that's the end of my presentation. Here are my references, and I'm going to pass it along to Bryce Weiniger, who is going to talk about vitamin C. Thank you.
Hello, everyone. My name is Bryce Weiniger, and I am an attending psychiatrist at Mass General Hospital in Boston. I'm originally from Indiana, like some of the other folks in this group, and I went to school there and then trained at Georgetown for residency and C-L Psychiatry fellowship at MGH, where I've been on staff ever since. And I work in our inpatient medical psychiatry unit, as well as doing collaborative care with 3 different primary care clinics. And I work in forensic setting doing asylum evaluations as well. And I really like this orange or grapefruit background, so I had to throw it in. So I'm going to start with a case presentation to illustrate some clinical information about vitamin C. And we have Mr. C, who was a 70-year-old guy I saw at my 2nd or 3rd month as a CL fellow several years ago, who had chronic renal failure and was dialysis dependent, had a history pretty remotely of depression, but had not been in any specialty treatment for it for a long time, for something like 10 or 20 years, who had a fall at home in the midst of commuting back and forth for thrice weekly HD with medical services at home, having detected that he fell, and brought him to the hospital. He, during HD one day, while he was being worked up for some electrolyte issues and sort of failure to thrive picture, he had reported in the chair right before they were about to start hemodialysis that he was having violent, very serious suicidal thinking, and reported this to the staff in the HD unit. So they called us to see him after doing safety precautions, and it turns out that he had very serious violent suicidal thinking, had apathy, amotivation, fatigue, and a lot of hopelessness. And so we started meeting with him pretty regularly, had a sitter at the bedside, met with him and his longtime spouse, his adult children, palliative care, his longtime PCP, and decided to expand the initial Failure to Thrive workup with a little more water-soluble vitamin panel, including thiamine C, and then also some fat-soluble vitamins that hadn't been checked in at the very beginning, like vitamin D. And the patient refused otherwise specific care for depressive symptoms like SSRI treatment or sleep medication, and actually continued to want to stop HD over a number of conversations. We did not have permission from him to take images. So these are stock images that looked very similar to his arms and legs with lots of skin changes that you can see here. And it took about 10 days for our send out vitamin C serum level to come back. I had to go all the way to Mayo Clinic and back from Boston. And at the time, this was not super common. It did take a while to both draw it properly in the right tube and also to send it out. It took about 10 days. And during that time, we did a lot of work with him and his family and the palliative care team. And ultimately, he was able to make more consistent, sort of decisionally capacitated decisions around HD, and was able to talk about it without the sort of violent, desperate ideation. His symptoms otherwise really didn't change, but he did allow for HD a couple of times in the midst of all that. And then ultimately, he was transitioned to comfort care only, which his family and PCP were both in favor of. And after just a couple of days on comfort only care and having missed only one HD session, he actually died on a Saturday afternoon. But what was really shocking to everyone involved was that that same morning at like 7 in the morning, we get urgently paged that his serum vitamin C level finally came back and it was non-detectable. There was none whatsoever that the lab could capture. And so he died having, alongside the other more chronic conditions that were known, something highly treatable, which was scurvy. And this was a shock to everyone involved. So a little bit, we'll swing back to talk about the history of the way scurvy has been thought of, and then get into more specific modern clinical discussion. It was first described by the Egyptians, 1500 BC, and then Herodotus described it in slightly more familiar terms in the histories. And then Dr. James Lind, who was a Scottish physician in the British Royal Navy in the 18th century, described it in the ways that we think of it as now, largely now, as a sailor's disease. So folks who are deployed, who are on long sort of journeys away from fresh foods and sort of normalcy, and certainly not just sailors, but also ground soldiers deployed far away from home also have dealt with scurvy. But this is really what got into the mythos of scurvy, was what James Lind had to say about it, and largely what we're taught in school now. And he gave this little quote here about how he recognized that neuropsychiatric phenomena certainly were the first signs that someone was suffering before maybe the more obvious physical signs, which is one of the big points to take away here. Later in the 20th century, we had our first neuropsychiatric study in 1971 that found that folks who were deficient dietarily and weren't supplemented had an awful lot of changes on depression scales, MMPI scales, lots of psychomotor changes. And this happened on an average of slightly less than a month of depletion, which you can imagine is easy to have happen in institutional settings, and arose well before physical symptoms, just like Lind noticed among sailors. In the 90s, the term corkscrew hairs and correlation with serum lab abnormalities first started showing up in the literature. And they saw that this had a direct connection to folks who went on to be diagnosed by neurologists with idiopathic Parkinson's. And the first an oxidative stress model of effects on the basal ganglia by lack of antioxidant was first proposed. In 2013, there was a big study in knockout mice where the key enzyme that humans lack, but that mice have to synthesize vitamin C in the liver, were studied, and they found that the vitamin C deficient mice who didn't have the gene and weren't being supplemented had a lot of reduction in novelty seeking, exploration, social engagement, and they craved sugar reward over their normal pellet food, and also showed lower grip strength and some other locomotor changes that were pretty detectable. And these rapidly returned to normal when they were repleted. And then one of the more recent ones, the critical care literature has been looking at vitamin C for quite some time, well before psychiatrists sort of did most recently. And they found that patients who are critically ill in the ICU who are showing signs of dyskinesias like tremors and rigidity, they could actually turn the dyskinesias and other Parkinsonism off and on like a switch with IV vitamin C, which is really interesting. And certainly, like with a lot of our other nutritional things we've been talking about today, there's a lot going on in those patients. And so that's one of many manageable elements of critical care. In contemporary populations, epidemiology studies tell us that in the US, among children and adults, we think vitamin C deficiency, and that means the really, really frank scurvy, as well as the more mild deficiencies that might not show super detectable symptoms physically. It hovers at about 6%. European adults up to 20%, which is interesting. And I'm sure that falls out along geographic and economic lines as well in widely variable communities. And then in US adults who live with poverty, about up to 20%. And US adult smokers, very similar across all incomes. So that's interesting. And then globally, there are some communities where vitamin C deficiency has been detected in up to 70% of residents. And that typically maps on the geography and poverty as well. In cohort studies, irritability is actually probably the most common neuropsychiatric symptom that we see over things like, for instance, apathy, fatigue, although those are very common as well. And we think that the hemorrhages, which may first show up as petechial hemorrhage in the skin or easily bleeding gums when brushing teeth, it takes at least the 20 to 30 days before you really start seeing that at critical deficiency, meaning that someone is really not getting any vitamin C with any meaningful amount that they can absorb. The WHO also sets some definitions about early or what they call latent scurvy as characterized by some of these neuropsychiatric symptoms too. So this is well recognized in a lot of global bodies or settings, maybe more so than the way we are talking about it here. I'm very proud of these animal pictures, these stock animal pictures of other critters that also don't make the vitamin C in our livers. Guinea pigs are one, and which also then make for a convenient lab animal. Fruit bats, which explains why they eat so much fruit, and some what they call anthropoid primates, including this very cute chimpanzee, are the rare mammals that can't synthesize a sorbate in the liver. And it's because we all lack something called the GULO gene, which is L-glucono-gamma-lactone. And that's an enzyme in the liver that catalyzes the final step of synthesis. So we have all along the evolutionary tree lost that ability. And it doesn't seem, as far as we know, that it's attached to any particular adaptation. And it may be just a pure chance that we don't have that anymore. A sorbate has a lot more functions than a lot of people realize. We typically first think of it as attached to collagen because we know that it causes bleeding and hemorrhage and things when we don't have it. But it's really, the relationship to collagen is that it is a cofactor in multiple enzymes that synthesize not just collagen, but also neurotransmitters, including the conversion from dopamine to norepinephrine. It is involved in the synthesis of vasopressin and in several other smaller molecule neuropeptides. And most folks don't necessarily realize those latter parts outside of collagen. It is an antioxidant at higher concentrations. We all kind of have a sense of that. We know that we see a lot of commercial products purporting to get some sort of immune benefit from high dose vitamin C. And there's a lot of mythology around that, but we do know it's an antioxidant that's important in critical care, in sepsis, and oxidative stress responses anywhere. And the critical care doctors have been very aware of that for a while. And it's important in the brain where the most oxidative energy exchange is happening anywhere in the body, up to 20% of all oxidative metabolism. And so there's a lot of oxidative free radicals floating around as a cost of that mechanism. And so an antioxidant is important in that space. Vitamin C also donates electrons and helps recycle other antioxidants, including vitamin E. It's an inhibitor of something called nuclear factor kappa B, which is a transcription factor involved in pro-inflammatory mediators, which may be one reason why it pops up in sepsis. and it is a binder of adrenergic receptors, so it increases catecholamine sensitivity, which then also pops up in critical illness and sepsis, and seems to participate when given to participate in blood pressure peripheral homeostasis. Vitamin C deficiency, we think from the last 50 years of studies, impedes basal motor nuclei activation. So that is probably the direct reason why the knockout mice, for instance, had changes, the septic patients had changes to willed movement, automatic movement. And this directly leads to things like apathy, PMR, and EPS before anything else shows up. And the neuropsychiatric symptoms may also arise because of a direct relationship to carnitine synthesis, which I did not list on the last slide, as well as the antioxidant ability. So not only are you not making carnitine, which has roles in mitochondrial transport, dopamine release, and synthesis of other neurotransmitters, but you also are having escalating oxidative free radical damage to key structures involved in movement, such as the basal ganglia. So this is sort of a two-hit way of getting at the same thing. It's really at the lower concentrations that ascorbate does the enzyme activity, and then the higher concentrations that it accumulates for antioxidant activity. And like I said earlier, this is particularly helpful in the brain where there's so much free radical presence because of how quickly the brain is burning oxygen. Similar to the heart, similar to some other structures, but certainly far and away more than any other organ. And this, I thought this was a nice analog that I read somewhere, that hypoglycemia first shows up with irritability and fatigue and not feeling well behaviorally before, potentially other peripheral symptoms, very similar to perhaps the way this works as well with vitamin C and oxidative free radical damage. There are some similar analogs that have been studied in what happens when other oxidative damage is happening to key structures, such as when copper as an oxidative metal leads to problems such as Wilson's disease, or when iron as an oxidative metal, we think has some role in things like catatonia and perhaps idiopathic and secondary Parkinsonism. And so this is not sort of new, that oxidating metals and with the lack of the high dose vitamin C and antioxidant activity can lead to direct sort of neuronal pathology. In terms of how we, the sort of bottleneck of how we get our vitamin C in, this is dependent on a couple of different genes that have to do with gut epithelial brush border and gut absorption, both in the gut and in neuronal tissue that helps concentrate. So it's SVCT1 and SVCT2. And so people, are on a sort of spectrum of what alleles they have for those genes that may or may not have a role in how they can concentrate vitamin C or not, despite their efforts in the diet. And another angle on that spectrum is that what we know is most people cannot really absorb more than about 500 milligrams of oral vitamin C at a time. So if you sort of buy a commercial product that purports to have a gram or something of vitamin C in it orally, it's very unlikely that you'll absorb more than 40 or 50% of it. And this is because of the brush border and renal absorption mechanisms. The WHO sets criteria for general scurvy, regardless of the peripheral or central symptoms, that really just includes having a history of inadequate dietary intake, having clinical features of bleeding, for instance, as the kind of old, obvious criterion, and then having biochemical evidence of depletion. And this is not necessarily operationalized or even recognized at most North American medical centers. This is not necessarily the criteria used everywhere, but this is what the WHO has had as a definition for quite some time. Other people more recently, including Dr. Brown, who wrote a very nice review article in Psychosomatics on this topic in 2015, propose a more flexible and sort of lower threshold for capturing neuropsychiatric scurvy specifically, that really takes the reliance on the physical symptoms off the table, since as we're now hearing, it is quite a late feature in the disease. And so he proposes, and I think I have really internalized this as a reasonable set of criteria when I'm working with patients, that first you look at, do they have evidence of basal ganglia motor nuclei dysfunction, extrapyramidal findings, psychomotor retardation, apathy, and affective disturbance first. So do they have neuropsychiatric symptoms at all? And none of those, of course, are specific just to scurvy. They could have a wide differential if you just knew that much. And then do they have evidence of hypovitaminosis C through either obvious findings? You can imagine how the A criterion would be helpful in settings where you can't get the lab or it takes a long time to get the lab. Or of course, you could check the lab if you're able to and note that it's low. And then it doesn't matter whether you have physical symptoms that have popped up yet or not, especially if it hasn't been long enough. And then if you think someone needs repleted and you replete them, those things should all get better pretty quickly. And so that's a pretty easy way to kind of prove the point. One thing to note is that low to normal serum levels. So if you catch someone who, for instance, the lab cuts off as just barely normal, say at a 0.5 or a 0.6, then that does not mean that they have adequate tissue levels. And that certainly does not mean that they have adequate neuronal tissue levels. And so it's likely that, in fact, the brain is more sensitive to that sort of threshold or subclinical depletion than what the blood sort of tells you. And we lose about 3% of our reserves daily. And the time to symptoms for some people who might be more vulnerable or been on the tip of frank deficiency for a while, they could start showing you symptoms within days, for instance, in the ICU or something like that. And another person might have a little more reserve and be a little more physically sturdy and might take quite a bit longer. And so this is all to say it's a wide spectrum, and you can't assume that a one-time level, which also would have taken days to come back in the first place, tells the tale. Factors that decrease availability and uptake include the following, which, like we're hearing with our other vitamins today, alcoholism is a constant, institutionalization, starvation, certainly absorptive diseases like Crohn's, celiac, surgical gut changes, and having food allergies that maintain pro-inflammation in the gut or really limit the variety of foods people are eating could both affect that. And having a high processed food diet, which is really common in the modern world, of course, including in the hospital for a quote normal diet in the hospital. Factors that cause resistance or increased demand. If you look at this list, you really see just about every patient that we get on the C-L service one way or another. So we have people getting neuroleptics. We have people who are wound healing, who are post-surgical, who've had burns, who are in high catabolic, high metabolic states. And they're really burning through the things that they need to stitch tissue, to deal with inflammation, to recover from serious physical hits more quickly than another person plugging along. And so we're seeing those patients constantly, almost by default of being in the hospital. Factors that accelerate elimination include the use of diuretics, the use of alcohol, smoking increases consumption quite a bit. And so that is the great equalizer that pulls people of different socioeconomic levels to the same prevalence of vitamin C deficiency in North America. Oral contraceptives, renal insufficiency, and hemodialysis also. So I wanted to share with you, we did a little study at MGH a few years ago during my fellowship here that was kicked off by this case patient who was also shared with slightly different details in this poster. And I presented this at the ACLP the last live meeting we got to have 2 years ago. And what we did was we started operationalizing criteria that I'll share blown up in a second for CL inpatients that we wanted to check levels on, and followed them for the most part of one academic year, about 9 or 10 months, and collected as many labs as we could get, and also collected what it was that was on their differential diagnosis according to our notes. So what we noticed were prominent exam features and differentials. And overall, we recommended many labs be checked, but we're only able to get 40 successfully back over those months. And that was because of a lot of operational issues, including the long time to send out, a lot of hemolysis, a lot of ignoring recommendations as we're all used to. So even though we recommended much more than 40, we only got 40 back. But among the 40 we got back, 82.5% of people had scurvy, either frankly deficient or mildly deficient, and in any event would require repletion. And so if we thought someone ought to be checked, we were almost always right, which is really interesting. And among I graphed out what people had on their exam descriptions or differential. So some of these are things like apathy and fatigue, which are not diagnoses. And then a lot of these are actual syndromes that we could note on a differential. And I want to point out that among our depression patients, 11 out of 18 ended up having some form of scurvy. Among our delirium patients, 14 out of 22 or 64% ended up having scurvy. Among cancer patients, 9 out of 10 or 90% had scurvy. And among alcohol use disorder patients, 5 out of 9 or 56% had scurvy. And something else to note is that bleeding and bruising was not common at all. And so we only captured bleeding and bruising in 4 total people, but everyone who did have bleeding and bruising had not just mild, but frank deficiencies. So that was 100%, which I thought was very eye-opening and a really great educational tool to capture this information. And one thing that shows up when you look at case reports and reviews of scurvy cases across emergency medicine, hematology, critical care, psychiatry, is a common theme is that you can kind of see the little lines here if you look closely, is that people do more than they need to do when they're faced with one of these cases. And so all of these tests, all these cases went through skin biopsies, bone marrow biopsies, neuroimaging, exotic sort of wide ranging lab panels that really went far wider than they needed to when they were staring at something that was very simple to treat actually. And after getting a ton of data and a ton of low yield from a lot of studies, ultimately it's vitamin C, and all of these patients with the pictures here all reportedly responded very quickly and well to cheap vitamin C repletion, despite the contributors for having had it in the first place across all comers. So we'll wrap up here quickly by pointing out a couple of things, including this is the treatment algorithm that differs between IV, oral, and renal impairment doses. And a couple of things, if you'd like to stop and read about myths that we can sort of respond to in terms of things that you might be asked as a consultant talking about vitamin C. And an operational sort of criteria that we use at MGH, where we are trying to check our catatonic patients, our new inpatients, and our delirium patients more consistently. That is simplified from the Brown criteria. Here are some references and a couple of quick final conclusions for the group in the way that we might flip the script on the things that we more routinely and rationally check, and limit our checking automatically, like at a lot of medical centers, of folate, of B12, of thiamine, where the yield might be lower, and focus maybe on things that are more rationally based, such as vitamin C and D, B12 when it's called for, and maybe less on the other two. And here's time to critical depletion for each of our vitamins that was provided by each author. Some of the marginal costs in-house at MGH at least, and these widely vary depending on lab fees, reagents that are used, but these are just the minimum costs that are reported based on the materials and those that are sent out. Some considerations for screening to check out that are reiterating what my colleagues have said, and the reminders about excretion and overload consequences that have also been stated by the other authors. And that's it. Thank you.